So in India, there's a lot of changes. We see a patient from poor socioeconomic status. We see a patient from very affluent class. We see a patient from very educated background. So as per the need of these patients, the changes in the structural heart treatment are also required. In about 10 years back, it was very difficult to treat these patients. So they again carry a very high risk. Now we have a technology by which we can fix their valve without any operation, which is known as the TMVR, transcatheter mitral valve replacement. We have now different type of mechanical valve as well as the tissue valves available, which requires a very low anticoagulation. The studies have been published and it has been seen that the new valves of various companies are available in the market for which you need not to go for a very high anticoagulation. I will say that new technology tissue valves are available. You put them, and after 10 years or 12 years when these valves will degenerate, we will give you a transcatheter valve which will last for 10 years. So I can give them a 20-25 year life without any anticoagulation or without any valve thrombosis risk. So this is a spectrum of patients who have a valvular heart disease which was not diagnosed before, and now during pregnancy, when the cardiac output is high, when the heart is functioning more, we got to know, because patient is having dyspnea, difficulty in breathing, and now we got to know that this patient is having a valvular heart disease. So these are very tricky patients. They require a multidimensional approach, means a heart team approach. Cardiologist, surgeons, physiotherapist, anesthetist, everybody, and psychologist, everybody sit together and counsel them. We try not to operate these patients because there is a lot of risk to baby and as well as to the mother. Maybe third trimester, when the baby is mature and there is no risk of radiation, we can take them to cath lab and just put a balloon mitral valvotomy. Here in our Eternal Hospital, we can give all these spectrum out to the patient. But it is important that the patient should be aware of all these facilities what are available. Now our treatment of valvular heart disease is changing with the age. Means patient is older age, go for transcatheter therapy. Younger age, in childbearing age, probably go for a tissue valve. Or middle age, see the profession, what profession going on, according to that guide them. There are now procedures are available which are giving very less pain to the patient. So we can ask patient to go for a minimal invasive aortic valve replacement or minimal invasive mitral valve replacement. So age, sex, profession and comorbidity, means any patient who is coming to you, maybe in the 50 years of age, but his kidney is not working, his lungs are very bad, the open heart is very high risk. Why not give them a transcatheter valve, or why not give them a small incision valve so that their risk will go down? You have a latest technology valves which require a very low anticoagulation, and their gradients is very low. Means if anybody who is in early 20s, they need a valve at aortic or mitral position. The latest technology valve, if we put them there, they can do a proper exercise. They can run, because there is very low gradient. It means they function so well that the heart is not burdened at all. Their functional capacity will improve like anything, which is very good for these young patients. Maybe 20 or 15 years back, we do not have these sort of things available. So if somebody comes to my OPD, I give them options. You can go for a minimal invasive valve, you can go for a full stenotomy valve. If old age patient, we give them a choice. You can go for transcatheter therapy, means no incision on your chest, we'll just give a transcatheter valve. If a younger age group, childbearing age, we ask them to go for a bioprosthetic valve. If somebody want a quicker operation, we ask them to go for a suture-less valve. So now the spectrum is changing a lot, especially to the heart valves. Even a mitral valve position or aortic valve position. The newer generation designs, newer generation valves are very, very hemodynamically good, and they give a lot of relief to patients. So now the practice, especially to the surgeons, is changing. But it is not the surgeon who is a deciding factor. It is the referring physician who is a deciding factor. So it is very, very important that education at the primary center level, and patient should be guided to a proper hospital where all facility of treatments are available, so they can be guided properly.